Right. Hi, everyone. Welcome back to the Rare Disease Podcast. We're now on season 8. Hopefully, you all caught our first podcast of the year, which was a special that I did with Emma just before Rare Disease Day. But if you didn't, then welcome to 2025. It is only April and already so much has happened. So we're going to do this intro and to the year so that we can then get on with the rest of the episodes. So today I will be covering our new branding, how Rare Disease Day went, that news about NHS England, and then also things that I've seen and enjoyed over the last few weeks that are related to rare disease. So sit tight and enjoy this episode. In January, Medics for Rare Disease had a change. We dropped the S from Medics for Rare Diseases, and we also had a brand change. And hopefully, you're all really enjoying it. I know that I am. So, we've also within that got some great new ways to communicate about ourselves because we used to get quite a lot of, I know you are, I know you do good stuff, but what is it you actually do? And that isn't ideal, really. And so, therefore, we really needed to make sure that we were being clear with our messaging as we go forth and make the differences we want to make. So, first of all, we dropped the number 4 from our name because we felt we'd grown up, and we dropped the pesky S from diseases. And this is because we actually advocate for a sort of single discipline approach to rare disease, whether that's in training or whether you're providing sort of basic care. So, obviously, not at specialist level, but when you're providing generalist care, it makes sense to have a broad understanding of what rare disease is and how it impacts people and challenges they may face and ways you may be able to help them. So we don't really concentrate on a single rare disease. So we got rid of that rare diseases. So here we are. I am Lucy Mackay. I am the CEO of the charity Medics for Rare Disease. And our vision is equitable healthcare for everyone. And our mission is to shape a medical profession that can provide a timely diagnosis and excellent care to people living with rare disease. And those are really important to us because that vision is not something that we can achieve on our own. We all know that Medics for Rare Disease itself is not going to get to the point where it is designing and providing equitable healthcare for everyone, but we can be part of that vision. And at the moment, people living with rare disease are rarely afforded, there you go, rarely afforded equitable care. And so often, actually, when you're listening to people's stories, we know that people aren't being provided equitable care because people will have heard things like, well, the condition is rare. What did you expect? When actually there's always something you can do for any patient. And we do this a lot in the NHS. There's a lot of situations where people live with a condition where there's no cure, or maybe it causes a poorer prognosis or or a limited life expectancy. And in there's plenty of cases where we don't just say, oh, there's nothing we can do, or it's rare, what did you expect? Or go home, make memories because there's nothing else. So that's what we mean by equitable care, is that when there is the support and the options and the management and the way people are treated are equitable. So that doesn't mean that we expect that every rare condition is going to have its own NHS service, or that there will likely be drugs for every single condition. First of all, those things are well out of our hands or responsibility. But we do believe that the fundamentals of good clinical practice apply to people living with any condition, regardless of its prevalence. So that's the vision. And then the mission is that we want to shape this medical profession. And we've been so lucky to work with so many different medical professionals over the years. And many people are on our ambassador program that absolutely demonstrate that medical professionals, regardless of their specialty, can learn and practice the skills that are required for approaching people with rare conditions in their practice. Lots of these are transferable skills from all sorts of medicine, but maybe because of the way we think about rare disease, or maybe because of the way we're taught about it, often all of these very proficient skills might go out of someone's mind when they are faced with that idea that this is a condition they've never heard of and that it's rare. And maybe that's quite scary for people. And we're just there to remind everyone that this population of people is about 6% of the population, and that's not including all their family and carers. So not only is this a large portion of the population who deserve equitable healthcare, but also our medical professionals already have those skills to be able to look after them and provide the basic level of care. We just need to do some training and education on how they can transfer those skills, and that's what we're there for. We also have new trustees. So at the end of last year, we sadly said goodbye to two of our founding trustees. So Dr. Hannah Grant and Dr. Deborah Fine, who have gone off to do other things now after dedicating, a decade, more than that, to Medics for Rare Disease, because I went to medical school with them and they were already helping out then. And we also said goodbye to Lindsay, who was our chair and came in, did a fantastic job, and is now doing other things. She's doing a project with the National Institute of Health Research. So thank you to those trustees. And out with them, and then in with some new trustees. So we kept Dan and Chris on our board. Dan, you'll probably be more familiar with. Dan Jeffries is an author and an advocate who lives with two rare conditions. He wrote the book Me, Myself and I, which is fantastic. He's quite hilarious. And I'm sure you'll have heard him on the podcast, or will do in the future. And Chris Brantz, who is in the background, making sure that the charity keeps pushing forward and achieving its purposes, the reason it was set up. And now we have three more trustees. So we've got Sheila, who is a very well-known rare disease advocate, used to work at NICE, and I've known for a very long time, so brings a lot of experience in this area with her. Emma, who works in global communications and has been really pivotal with getting our brand done, because she works at Emotive, and that's who provided us the pro bono work on our brand. We've got Harriet, who is a CEO of a completely different charity, but has children with a rare condition. And lastly, Russell, who is a GP and currently works for NHS England in sort of GP training, but we'll get on to NHS England later. So they will be coming along this season to introduce themselves on the podcast. So make sure you tune into those. So that was January. And then quickly after that, we had to switch gear, ready for Rare Disease Day. And thank you, everyone who took part. And this is only the third year we've done the Show Your Stripes sock campaign. But it was the first year we did it with branded socks. And Emma wanted these branded socks, Emma Huskinson. And she sourced the place in Cheltenham, M&M Creations, and she got them made, and they looked fabulous. And we did not expect to have requests for nearly 800 pairs of socks. We thought they would last us a lot longer. We've even been asked, where's the shop? We need a shop for these socks. So yes, that's given us food for thought. We had a lot more. We had lots of people taking part and sending their photos. We had requests from all over the country, and the majority of the requests for like bulk orders, so that means that we'd package up a load of socks and send them to somewhere, were from GPs or pediatricians. So people in the NHS, these socks were going to. We really did have them from all over. So I remember a lot of Glasgow, Manchester, but Wales, Northern Ireland, the South. We really did have this broad geography of requests for these socks. And one of my favorite moments, I went to the parliamentary reception with Genetic Alliance. And we'd sent out all of these socks in red envelopes and sent them to MPs and peers in the House of Lords who have shown an interest in rare disease or involved in health. And in walked the minister, Ashley Dalton, and she's wearing this amazing light pink trouser suit. And there she is wearing these zebra stripe with mint flash rare disease socks, Medics for Rare Disease socks for Show Your Stripes. Oh, it was amazing. And we got some really great photos. My MP, Freddie Van Mierlo, he also did it, which was great. I think we got a few of our MPs doing it. And I think really what this is saying is that they, there's this, we want the people who are representing us in Parliament. This isn't about parties or who you support, but this is about, if you've got an MP, they've been elected, maybe not by yourself, or maybe by yourself, maybe you voted for them, but they have been elected to look after you and the issues that are important to you or impacting you or people you love. And so having MPs be aware of this community and their needs is really, really important, because they're not going to be able to provide informed opinion or ask the right questions if they don't even know the number of people who are impacted by rare conditions in their constituencies. So it's really great to see people within Parliament getting involved in Rare Disease Day, whoever they are in the country. So that's Rare Disease Day. I guess, what's next? NHS England. Yeah, that hit us, didn't it? If you have been living under a stone, or, maybe quite fairly, you try not to watch the news too much, you may not have caught this, but a few weeks ago, on quite a random day, I can't remember, I was at the office and it really took out my whole day of work, because suddenly people were asking questions about it. But Keir Starmer announced news about NHS England. And I have to say, I was quite surprised about a few things. But basically, I knew that NHS England, oh, sorry, my screen is in the way. I knew that NHS England had already, a lot of people had been made redundant or jobs had been lost. And I knew that there were plans for more. But this is not not totally what I was expecting. So first of all, before I probably get into this, one of the first things that I saw people reacting with is, oh my gosh, what's happening to the NHS? So I think it's really important, and maybe this is a important point on comms for the Prime Minister. Not that I would dare to give advice for someone who can lead the country, but one of those things of, first of all, people were saying, oh my gosh, they're getting rid of the NHS. So this was not about Keir Starmer abolishing the National Health Service in England. NHS England is not the health service itself. It's I think it was termed an arm's length non-governmental body that would decide the sort of focus and be accountable for the NHS and its outcome. So that first thing, so it's not that the NHS in England is going. That was one of the biggest things. The other thing was that I found really interesting was the timing of this was just around what's going on in the US, where I won't get into it too much, but where there's this whole Department of Government efficiencies where lots of departments are being sort of scrapped or closed or whatever in the US by its fairly new government. And that was quite interesting to me, because I had people saying, oh, it feels like what's happening in the US. And they're kind of, what they were saying around this is that looks quite scary, the way that some people feel that Elon Musk is sort of gutting all these departments and things in the US. And So again, there was that funny communications of at the time that this broke, the idea of just getting rid of departments is sort of already out there in the global mind and social media because of this whole Doge thing in the US. I would also say this is also not that. We must remember that NHS England has not been around forever. It came in during the, I believe, 2013 health and social care reform. And so that's, it is only about just over 10 years old. So there was an NHS before and there will be an NHS after, but not to, diminish the fact that this is a big move on behalf of the government. And this is what he said. Keir Starmer said on the day, "I'm bringing management of the NHS back into democratic control by abolishing the arm's length body NHS England. That will put the NHS back at the heart of government where it belongs, freeing it to focus on patients, less bureaucracy, with more money for nurses specific." So that was one of his main things. I was quite interested in his use of the term abolish. That's a strong word. I have to say, when I originally saw it, abolish, I thought it was clickbait or something. So abolish is a really strong word to use. Like, listeners, let us know what you thought. But to me, when I think abolish, I think there's probably two things that come to mind. First and foremost is slavery. Is this anyone else? I just think that when I think abolish, I think of the abolition of slavery. And then maybe next would be abolishment of the death penalty or something like that. So it's quite a strong word to use about a organization that's made up of like nearly 20,000 civil servants. So that, if anyone's got any insights or had any thoughts on that, do let me know what you thought about that, because whatever you think about NHS England, and I don't know if anyone thinks that much about it, except for people really, really involved in it, abolition feels quite strong. Anyway, so since then, there's been a lot of reaction. So first of all, we've got over the fact that this isn't the NHS itself going, and that it doesn't look like it's the equivalent of what's happening in the US. The next step is, what is happening and how is this going to impact people living with rare conditions? So I took to LinkedIn, because that's where it's at, everyone. If you're not in LinkedIn, where are you? So I took to LinkedIn and just did a quick post. I also have to say we did email some colleagues that we work with within NHS England, just saying, this is a big piece of news. We hope you're being supported, and to thank them for the work that we've done with them. I wrote, "The rare disease community was already facing uncertainty with the UK Rare Diseases Framework expiring in 2026. And now we have news that NHS England is being disbanded. NHS England is one of the handful designated delivery partners for the England Rare Disease Action Plan. And Medics for Rare Disease was told explicitly it couldn't be a delivery partner despite its expertise in England. However, this wasn't the case in the other three nations." So I wrote a little post about this, and then actually got quite a lot of replies, and people brought up some really interesting and valid points. I don't think they necessarily have answers now, but they're definitely worth exploring. Also, my husband brought up the valid point that it might be a little bit complicated for those who don't know anything about this. So the point is that NHS England was, created just over 10 years ago. And it sort of meant that we have a government and a Department of Health that is, that answers to the Secretary of State for Health, so for answers to the likes of Wes Streeting. And then we had NHS England, this arm's length body that was also involved in delivering health and making those decisions. And what Wes Streeting is talking about, when he first came on, he said, because I think anyone in this area might know that it hasn't, we've watched NHS England's jobs be cut and cut and cut. So I don't think it's a huge surprise that thinking about the future of NHS England was on the cards. And in fact, all of the people out there who are health journalists will have been talking about this for years, not just weeks. But there were these questions of, will NHS England be reformed? And everything redesigned, etc., which I think leads most people to go, oh, another reform. But I've heard Wes Streeting talking on this, and he talks about the devolution of power to the front line. So while this is a reform, it sounds like he's talking about reforming the top layers of NHS England. NHS England has a really, really big budget. I think we're talking billions here. And so talking about, instead of having NHS England and the Department of Health, going back to having one leadership body. And therefore, yes, it means that lots and lots of jobs will go, but that will come with cost savings. So, and he says about devolution of power, so giving back power from this body called NHS England to the people who organise health in the community. And he calls it the front line. So I guess that means to the people who are actually providing healthcare services. He also talked about having national standards that are supposed to be met so that there wouldn't be differences depending on your postcode. So something called a postcode lottery. And talking about nationalisation of procurement. So that means when we get our materials, or, where all of our syringes or all of our sort of supplements or something, that this is done at a national level so that we can make cost savings there and get better value. And the last one, he was talking about innovation, medtech, and research. And I think that's the place where I'm most interested in where we go with our NHS England when we're talking about rare disease. So some of the things that came up on my LinkedIn post is, what do you think this means for NHS highly specialised services? Now, highly specialised services are services that get paid for or are commissioned nationally by NHS England, because maybe the medicine is so expensive, you couldn't expect a GP or a hospital to pay for that out of their budget that they've been given. So therefore, to make sure that people who require these really expensive drugs or this expensive service, to make sure they still get that service, it's paid for nationally. So, that's why you might have people who live in Leicester, but, we're thinking about Aisha, but she'll go to a metabolic service in Manchester, because that service is commissioned, it's paid for in a certain model. Now, these services only exist for a very small population of people living with rare conditions. So when we think about that, what does this mean for highly specialized services? There's the other side of the coin on this of, okay, we let's take it at face value. We do not want to find people who have had access to specialist care and treatment, regardless of their price, lose that because of this reform. I think that you can just take that as said. We don't want people losing healthcare. But the way that this is set up at the moment means that it can, when it comes to rare conditions where there's over 6,000 of them, and the vast majority of them do not have a disease-specific treatment, the method of having highly specialized services for rare disease, or thinking that highly specialized services equals rare disease, is inherently flawed. It's highly specialized services is a commission, is a paying model. It's not a model for looking after a large group of people, 6% of the population living with a rare disease. So my reply to that about what do you think this means for highly specialized services, I think, and maybe this is a bit controversial, is I don't think within rare disease we should only be thinking about one portion of the population because they do have a service. I think it should be, like I said earlier, it should be absolutely expected that if someone was receiving this treatment and care before, that they should be able to receive it still, if that is what is indicated and that is what, they should have for their healthcare, regardless of the plans to reform. But by concentrating on this small section, we sort of don't therefore look at the larger proportion of people living in rare conditions who don't have a highly specialized service and most likely don't have a specialized service. So maybe we could design a system where your opportunity to get healthcare is not, when you live with a rare condition, isn't based on the model of paying for that healthcare by the government. Because if I had a rare condition or if my child had a rare condition, I want them to have the appropriate healthcare. I'm not that fussed about the paying model that is used by the government to the NHS or to the hospital. I want them to have healthcare, and that's their human right. So I hope that as a rare community, we don't get too bogged down in worrying about loss of what people would call progress for some and not thinking about, well, hang on, could there be progress? Could we maybe keep hold of that, but also have progress in terms of more appropriate care for the rest of the community? So again, yeah, it's a few about highly specialized services came. I think another one that was really interesting, it was from our dear friend Artie, who used to work at Unique and is a independent advocate. She said, as a patient, I'm rather worried about what this means for the future of commissioning specialized services that many rare disease patients have. And she gives the example of her hearing aids, which are, prior to this, she says, were funded locally. And that meant it depended on what the decisions that were made locally, whether people routinely were funded to get hearing aids or not. And that there were long delays, unequal access to hearing aids, and there was no nationally agreed clinical criteria. I mean, that's awful, isn't it? Again, if you require a hearing aid to hear, I think again, it's this kind of, clearly NHS England has done good things. We do not want to lose them. But that doesn't, hopefully we're not going to lose the ways that we've provided better care for people going forward. So we need to make sure that, okay, maybe there are opportunities with this model going, but as a rare community, we've already had two examples, whether that's highly specialized services for conditions with quite expensive drugs, or whether it's the, absolutely critical provision of hearing aids to people. These are things that people are worried about having taken away from them. I mean, even saying that is kind of bizarre, isn't it? To think that people are worried about losing their healthcare because of a change in reform. I don't know if that's real, if that can happen, or whether that's, it's people going, it sounds like Artie doesn't want to go like that's how it was before. Maybe I would argue that they can't if, we need to just keep raising our voices. But while we raise our voices, let's try to be inclusive of everyone within rare disease. Sharon wrote that, she wrote that my host explained things better than she can. and that she says one of the biggest problems with the rare genetic condition in her family is a lack of healthcare professional awareness and knowledge. I mean, if we're then going to come on to what Medics for Rare Disease does, and whether having NHS England, not having NHS England, if that helps, I can only go on my experience, which is I didn't do policy prior to the UK Rare Diseases Framework that was published in 2021. I don't, we did consultation for it. I have not studied policy, etc. I have learned on the job. But because we are disease non-specific, and because what we can do can cross barriers quite easily, it doesn't need to come into one of the 4 nations. And because we're a charity, so we can move, we can be quite flexible. It was really noticeable to me that once we got past the framework, which is the policy brought in by the Department of Health, the 4 nations then had to make action plans. And how the 4 nations in the UK did that were all very different, except for England really stood out that the other 3 nations did have sort of a consultation group who included charities, people with lived experience, clinicians, etc. And they went away and formed their action plans. Whereas in England, our action plan was designed by people who the Department of Health worked with. So it was basically sort of NHS England, Genomics England, which is a research organisation, NIHR, another research organisation. Trying to think of other organisations on there. But Medics for Rare Disease could not be a delivery partner even for priority 2 of the action plan. We could in Wales, but we couldn't in England. Everything had to go through NHS England. So if there was training that was required or awareness that was required, it had to go through NHS England. Obviously, Medics for Rare Diseases was still working in this field. So we did, and we did get to work with a really great team within NHS England, the genomics education program. But it seemed to me so sort of arbitrary and inefficient that when you've got organizations who already do these things, that they can only provide consultation. So Baroness Blackwood and her team went around asking all of these groups and all of these people, what would you do? What would you like to see in rare disease? But when it came to England, none of those people could actually do any of the doing. You had to be basically NHS England to do. If I use NHS England here because we're not a research-based organisation. So anything that we wanted to do, anything for priority 2 had to go through NHS England. And I think that became a real problem for 2 reasons. One, it's NHS England that had been around for those years where people had experienced problems with these things. So there's an element of, unless you've got a grand new plan and budget behind it, how is this going to make any difference on these things? And the second side to that is that there's a lot of experience and worth and connections in what charities and other organizations do that clearly were good enough for the consultation period, but were then not allowed into the application period with the action plan. So that meant that for any real systemic change in rare disease, we had to, these groups had to find a way to work with NHS England. And that does cause barriers. There was this sense of it has to be done in-house, if that makes sense. Obviously, we do workarounds. We're great at collaborating, so we've done what we could, but it did feel like there was this loss of opportunity in England that there wasn't in other nations. But also, lastly, it means when you come to the action plan and its results and all the great things that have been done, if you look at the England report, it really doesn't represent all the great things that have been done in England, because it's only the things that have been done by those official delivery partners of the Department of Health. And, that's a shame because the landscape is not the same as it was in 2021. Healthcare professional awareness, just from our Rare Disease Day campaign, it has improved greatly. We know that we're working in a completely different environment than we were 5 years ago. So if that's not then reflected in the sort of the follow-up of the policy, I think it's sad because you don't get to get that message of hope and look at all these great things that have been done out there. So for me, I guess the hope is that with if if we are to listen to what the government says at face value, I really hope that we get to continue working on the things that have been incredibly helpful that NHS England have provided. I absolutely expect that people continue to get the health services that they were having before this change from NHS England. But I also hope that by having only one sort of leadership group within healthcare in England, so just the Department of Health and not this other arm's length body, I hope for two things. One, the needs of the people are reflected in what is created in terms of NHS health and innovation. But also, two, the person who has been elected and therefore the person who has been voted in is then responsible, because that would be sort of Wes Streeting is then leads the Department of Health. So therefore, if things aren't going well, he can't deflect it to NHS England. We can hold him responsible for what is happening in terms of health and social care in England again, which had kind of changed with the Reform Act. That's important because Wes Streeting has his job because he was voted in as a member of Parliament. Regardless of your politics, he has been voted for. He can lose that vote. That is possible if people don't like what he does. The difference with that and say positions in NHS England is they're undemocratic. They are people who are employed into it. That doesn't mean necessarily that is bad, but it means that the person who has been voted for is not the person being held responsible for the healthcare in England. And that's my biggest hope from this is, okay, now if someone isn't getting their hearing aids or people do start missing out on treatment, the person that we can go to say this isn't okay is a voted in member of Parliament and has to answer to it. And I'm not sure how that worked with NHS England because I don't know the ins and outs of it. But I kind of find that exciting because I think it puts the government and the people back into the government having that responsibility, and the people can let them know how they feel with their voices, with all of those parliamentary systems, as inefficient or brilliant as they are, whatever you like to think. And ultimately, if someone is doing well or isn't doing well, that can be reflected on whether they are voted back in as an MP. And then lastly, I wanted to come to the innovation and research. This is where I am quite as confident, because in this interview, Mr. Wes Streeting MP said, in terms of innovation, medtech and research, we want the NHS at the front of that revolution and actively driving it. And this whole idea of the NHS being used to drive innovation, let's see how it goes. Because if we're looking at the rare disease community that has in the last 10 years, whether it's been AI or genomics or gene therapy or all of these sorts of innovations, which in themselves are tools. They are very much worth the investigating and developing if that's going to help people. But I do feel like they have become the patient. They're the ones we're working for. It's the development of those things rather than the benefit that those things can bring for the patient. So this would be my wish and hope, is that the NHS isn't at the forefront of a revolution in innovation and medtech and research, but the NHS is at the forefront of care for its population. And that includes innovation, medtech, and research where that's going to benefit those population. I worry about health being used as people's health being used as a impetus for just a generic innovation growth agenda. Because what happens if it doesn't benefit that person's health? Where do they then stand? And where do they then go if their healthcare service is going for innovation rather than for patient benefit through innovation? It might sound subtle. And, this is all just what I've digested over the last few years. I remember when the NHS Reform Act came in, actually, when I was a medical student, and it was the Health and Social Care Reform Act with Andrew Lansley came in. It was a big deal. It was a big deal. I will be really interested to see where this goes, but not just interested. We need to get out there talking about what do we want to see. I don't think anyone has come out saying, this is absolutely ridiculous. This should never happen. We shouldn't be downsizing NHS England, or we shouldn't be merging what happens in NHS England with Department of Health. I've not seen anyone do that. So instead, let's not drive forward with fear, like what if this and what if that. Let's make sure the fears don't ever happen, but also ask for what we need and make those needs clear. If you were going to throw this whole thing up in the air and let it land again and think about equitable rare disease care for everyone, what would you want to see? How does that happen? Because actually, I think lots of people involved in this would love to know. And this is an opportunity potentially for us to, as a rare disease community, to shape healthcare that is more equitable for the whole community, and rather that concentrates on pockets of the community. Okay, that's my NHS England chat, and hopefully it wasn't too arduous and you do understand it. If you don't, I'll have to try and get a bit simpler. So last things to talk about, things that I've been enjoying. First of all, is Am I Being Unreasonable, the second season. If you have not watched Am I Being Unreasonable, I'm so envious of you because you are still fresh and haven't already watched it, and therefore you get to experience watching it for the first time again. It's on BBC. And it's got the incredible Daisy May Cooper in it. I think she actually wrote it. And it's got Lenny Rush, who is a comedic actor. He's been in quite a few things now, and he has short stature. And in the program, he uses mobility aids, etc., etc. But it's just brilliant to watch because it is a absolutely brilliant program about the messiness of life. And within it, you've got Lenny living with a rare genetic condition that causes a visual difference and a form of disability. And this program is nothing to do with that. He's an actor. And I love it. And I think the on-screen relationship between him and his mum, who's Daisy May Cooper, is brilliant. I know I grew up with quite a lot of people with like sort of a congenital short stature from different conditions, and there's some great bits in it that really remind me of those friends and how they might live their lives and remind me of those friends. And then lastly, a video that my daughter is absolutely in love with, and I'm really glad that she is. It's it's called No Decision About Us, About Me Without Me, which was a thing that came in the NHS, No Decision About Me Without Me. But there's this video, I think it came out on the International Day for Down Syndrome. Bear with me. It's called No Decision Without Us, World Down Syndrome Day 2025. And it has me and my family just going, I want to be where the decisions are made. So we'll link to it. But I mean, it's just fantastic. And it features people who are deaf, people with amputations, people using wheelchairs, and how they want to be where the decisions are made. And it is so snappy and it is just brilliant. So go check that out because I loved it. Anyway, I've talked on and on, mostly about NHS England. Thank you if you stuck with me. I really hope you enjoy this season of the podcast. We have Lexi talking about sex and gender. We have some reviews again with Dan and Emily. We've got our new trustees coming on, Dr. Hannah Brew, who's a GP and has a rare condition. So we've got loads of great episodes coming up. Make sure you do rate, review, and share so that we can spread this podcast even further, because recently we got to 10,000 downloads. So I want to get that even higher. And thank you very much. Enjoy the rest of the episodes.